Yes, sir. Start, sir.
Hello.
Start, sir. Start.
Shall I proceed, sir?
Yes, sir.
So, good morning to all my dear students. So, first of all, on this occasion, so I would like to thank to Government of Andhra Pradesh, JNT Anantapur, and JNT Kakinada for providing this wonderful platform to all the students. Coming to myself, Dr. Sannithi Nagarjuna, Faculty of Pharmacology.
Hello, sir.
I'm working as a coordinator for GPAT cell in Raipur, Anantapur.
Sir, mobile sir.
As well as I'm the coordinator for Hyderabad Academy and Online GPAT Academy, which are providing coaching for GPAT since from last 10 years. So today's topic is about pharmacodynamics. So we are going to discuss about in detail pharmacodynamics. So we all know that one of the major subjects in pharmacy is pharmacology. Pharmacology is a branch dealing with the study of drugs. If you want to understand about the drugs, to pharmacology, we know that there are two major branches in pharmacology. One is pharmacokinetics, another is pharmacodynamics. So pharmacokinetics deals with 4 parameters like absorption, distribution, metabolism, and excretion. And coming to pharmacodynamics, which deals with mechanism of action and pharmacological actions of the drug. So our present topic is about pharmacodynamics. So it is a branch of pharmacology. So deals with the study of mechanism of action, pharmacological actions, and uses of the drug. So simply we all know that pharmacokinetics means what the body does to the drug, and our topic is pharmacodynamics, is nothing but what the drug does to the body. So you can simply say that pharmacodynamics means it is a branch dealing with the mechanism of action and pharmacological actions of the drug. And we can see also that it also refers to the relationship between drug concentration at the site of action and resulting effect. And if we come into the mechanism of action, we all know that most of the drugs in pharmacology produce their mechanism of action by binding to the receptors. So drugs will produce their mechanism of action by different modes, but the most of the drugs in pharmacology produce their mechanism of action by binding to the receptors. So today we'll see in detail about the receptors. So what are the definitions, types, examples, and how those receptors mediate the pharmacological actions, everything one by one we'll see. So coming to some of the definitions here, the first definition is receptors. So we all know that what are receptors is, they are defined as specific binding sites for drug molecules or ligands, and chemically all receptors are protein in nature. So a simple definition here is, our body is made up of several proteins, am I right? But out of all proteins, some proteins will act as binding sites for drug molecules. Those proteins are called as receptors. So mean to say all receptors are chemically protein in nature, but all proteins are not receptors. So whatever the proteins will act as binding site for ligands or drug molecules, those are called as receptors. So actually what is ligand is another definition. So which is a substance that can selectively attaches to the receptors, activates the receptors, and produces maximum pharmacological action. So try to understand, it is a substance that selectively attaches to the receptors, activates the receptors, and produces maximum pharmacological action. Always receptors and ligand both are highly specific and selective. So mean to say that one receptor binding site for one specific ligand, one ligand fully attaches to one particular receptors. So both are highly selective and specific. If you come into ligands are always endogenous substances. They are present in our body and to the receptors and they produce their action. And coming to these examples for your better understanding, so receptors and ligand. So there are different receptors and their respective ligands. If you see here, first one, cholinergic receptors. For these cholinergic receptors, ligand is acetylcholine. Then adrenergic receptors, for this ligand is noradrenaline. The histamine receptors, for this histamine. For dopamine receptors, dopamine. For serotonin receptors, it is serotonin. And for GABA receptors, GABA. So try to understand. If you see easily, you can understand that these are all the examples of receptors and these are all the examples of ligands. For cholinergic receptors, acetylcholine means you can understand here easily the nomenclature of receptors. As per IUPAC or International Union of Pharmacology, the nomenclature, the naming of receptors is based upon the name of the ligand. So I told you already the receptors are proteins. Their duty is binding sites. They are binding sites for ligands. So based upon the name of the ligand, we are giving name to the receptors. The receptors are binding sites for acetylcholine, hence they are called as cholinergic receptors. The receptors are binding sites for histamine, then they are called as histamine receptors. The receptors are binding site for dopamine, then they are called as dopamine receptors. Likewise, you have to understand. So coming to the another two words, affinity and intrinsic activity. So what is affinity is, we all know that easily. So compound is having affinity, means it is having ability to bind with the receptors. Intrinsic activity, it is having ability to activate the receptors and produces the pharmacological action. Got my point? There are two words. One is affinity, another is intrinsic activity, otherwise called as efficacy. So affinity means capacity to bind with the receptors. Intrinsic activity means capacity to activate the receptors and produce the pharmacological action. So intrinsic activity is otherwise called as efficacy. So you try to understand that whatever having affinity may not produce the action. So there are two important terminologies here. Just capacity to bind with the receptors called as affinity. Capacity to activate the receptors and produce the pharmacological action is called as intrinsic activity, which is also known as and called as efficacy. So coming to the two major words in pharmacology we should know and we should understand is, one is agonist, another one is antagonist. So the total pharmacology is revolving around the two words majorly. The drugs in pharmacology is always two types, either belonging to the category of agonist or antagonist. So agonist means which is having affinity as well as maximum intrinsic activity. So means intrinsic activity is +1, means it is 100%. So from that we can easily understand that agonist is having the ability to bind with the receptors and activate the receptors to produce the maximum pharmacological action. If you see, look onto the ligand. So for ligand also we'll say the same thing. Activate the receptors and produces maximum pharmacological action. Even here also, agonist produces maximum pharmacological action. But the difference is, agonist ligand both are same. The only difference is, agonist is exogenous and ligand is endogenous. Try to understand, I told you already. Ligands are endogenous substances synthesized inside the body, bind to the receptors, produce the pharmacological action. And agonist is same as that of ligand, but agonist is exogenous, given in the form of a drug. Mean to say that the ligands are endogenous substances like our neurotransmitters, hormones, steroids in our body. So acetylcholine, histamine, dopamine, GABA, serotonin, whatnot, which will all act as ligands. Agonist is what we are taking in the form of a drug from outside, which produces actions similar to ligand. So why we have to use agonist is, suppose if you take acetylcholine is one of the ligand, endogenous substance, bind to the receptors and produces its actions. Suppose if any individual is having deficiency of acetylcholine, what we have to do? We have to take acetylcholine, right? But if you take acetylcholine, what happened? The acetylcholine undergoes very faster metabolism, faster degradation. Its action is there only just for 2 to 5 minutes. So that we cannot take acetylcholine. So that what we have to take? We have to take drugs which produce actions similar to acetylcholine. They are called as agonists. So that is the meaning of agonist. Agonist produces actions similar to ligand, or agonist increases the actions of ligand. The only thing is agonist, ligand both are same. Ligand is endogenous, agonist is exogenous. The point is, whenever we have a deficiency of ligand, but we cannot take ligands as it is because of some demerits like faster metabolism, less absorption, unable to cross blood-brain barrier. The reason may be anything, but we cannot take ligands as it is, so that we are taking drugs. They are called as agonists, which always produce actions similar to ligand. So coming to the antagonist, the same thing. Antagonist means which is having affinity and which is having no intrinsic activity. Here intrinsic activity is 0. So which is having affinity, but the intrinsic activity is 0. Means the antagonist only bind to the receptors, but it will not activate the receptors and it will not produce any pharmacological action. So got it now. Antagonist simply blocks the receptors. I mean to say that it will only bind to the receptors, but it will not activate the receptors and it will not produce any pharmacological action. So mean to say that the antagonist role is which will block or stop the actions of ligand. Hence it is otherwise called as blocker. What about? So means agonist, antagonist, right? To understand. Agonist produces actions similar to ligand. Antagonist will stop the actions of ligand. So from this, what we have to understand is our body is having several receptors, several ligands. Ligands are endogenous substances, neurotransmitters, hormones, steroids, whatever it is. They bind to the receptors, they produce their own actions. But whenever ligand concentrations altered inside the body, some abnormalities will come. To treat that abnormalities, we are using drugs. Those drugs are in the form of either agonists or antagonists. The agonists are those which produce actions similar to ligand. The antagonists are those which will stop the actions of ligand, otherwise called as blocker. So try to understand that. So this is what you have to familiarize with the words agonist and antagonist. So I'm telling once again, please. The receptors are binding sites. They act as binding sites for endogenous substances, ligands, as well as for drugs. And chemically, all receptors are protein in nature. The substance that can selectively attaches to the receptors is called as a ligand. And these are all the examples of receptors and ligand. And capacity to bind with the receptors called as affinity. Capacity to activate the receptors and produce the pharmacological action is called as efficacy or intrinsic activity. So agonist is one which produces actions similar to ligand. Antagonist is one which will stop the actions of ligand, which is otherwise called as blocker. So this is what one of the representation give you, the comparison between agonist and antagonist. See here, if this is a receptor. If the agonist binds, the full activation of receptors will happen. The maximum pharmacological action will be observed. The antagonist will bind. it will block the receptors, then no pharmacological action will be observed. So this is another representation you can see here, same thing. So endogenous ligand, see they are using the word ligand is nothing but endogenous, effect will be observed. Agonist, same effect as that of ligand. The antagonist, you cannot observe any effect. So some of the examples of agonists and antagonists to the ligands. Same thing I told you, the endogenous substances will act as ligands. One such example is acetylcholine. For those, agonists are carbachol and methanocol. For that, antagonist is atropine. Likewise, you can take anything. Noradrenaline, agonist is dobutamine and antagonist is propranolol. So likewise, you can take a number of examples. The examples for agonists and antagonists to the receptors. And coming to the next important topic, types of receptors. So types of receptors. So if you see receptors, always the common property for receptors is the receptors will not exist as alone, single, and they are always present in coupled manner and present in attached manner. So based upon substance, the receptor is classified into 4 types. So if you come into receptors in our body, receptors will not exist as single, separately. They are always attached to some. They are always present in some manner. Based upon the coupled substance, to what substance the receptors are coupled, the receptors are classified into 4 types. If you see here, likewise, we all know that there are 4 types of receptors. G-protein coupled receptors, ionotropic receptors, enzyme linked receptors, nuclear receptors. We all know that these words. How and what basis we are giving name to this is, so G-protein coupled receptors means the receptors coupled to G-protein. Ionotropic receptors mean the receptors coupled to ion channels. Enzyme linked receptors mean the receptors coupled to enzymes. Nuclear receptors mean the receptors coupled to nucleus. So likewise, means receptors are not separate entities, they are not single entities, they are always coupled to something. To what they are coupled is different from one receptor to another receptor. Based upon that coupled substance, we give a name to the receptors. If the receptors are coupled to G-protein, called as G-protein coupled receptors. If the receptors coupled to ion channels, ionotropic receptors. If the receptors coupled to enzymes, called as enzyme linked receptors. If the receptors directly coupled to nucleus, they are called as nuclear receptors. So these are the 4 major types of receptors. But out of all these receptors, most of the receptors belonging to the family G-protein coupled receptors. Out of all these receptors, most of the receptors belonging to G-protein coupled receptors. Now we'll see about G-protein coupled receptors. They are very important. If you understand these, you can almost understand about 80% of drugs in pharmacology. So coming to the first, location of receptors. These receptors are located across the cell membrane, within the cell membrane. The receptors are located within the cell membrane. So we know that intracellular means located inside the cell. Extracellular means located outside the cell. But these receptors are located within the cell membrane, across the cell membrane. Henceforth, these receptors are called as transcellular receptors. The meaning of transcellular receptors is the receptors located across the cell membrane. If you see here, there are 2 parts as we discussed. Receptors are coupled to G-protein. So one is protein and receptor. 2 separate entities here. One is the G protein, another is the receptor. Now we'll look on to the structure of those two entities. If you see the receptor consists of 7 helical structure. You can say that 7 transcellular helical structure. I think we have seen the textbooks, 7 helical structures, 7 transmembrane segments. And the receptor is having 3 loops. And we all know that the receptors are chemically proteins. Proteins means made from amino acids. So they should possess functional groups like NH2 and COOH. This NH2 group is present on extracellular side. And COOH group is present on intracellular side. So see this structure of receptor. The receptor is having 7 transcellular helical structures, 3 loops, NH2 group present on extracellular side, COH group present on intracellular side. So coming to the G protein, this G protein is trimeric in nature. Trimeric means we know that it is made up of 3 subunits. Those are alpha, beta, and gamma, and all these subunits are attached to GDP. So we know that in the G protein, the G stands for GDP. Always remember, guanosine diphosphate. And this protein is trimeric, having 3 subunits called as alpha, beta, gamma. So see now, this is the G protein, this is the receptor. Both are always attached, called as G protein coupled receptor. The receptor is on the cell membrane called as transcellular receptors. If you look at this, having 7 helical structure, 3 loops. NH2 group will be present on extracellular side, COH group present on intracellular side. This G protein, where G stands for GDP, protein is having 3 subunits, having alpha, beta, gamma. All these subunits are attached to GDP. Now, how these receptors will carry out, will mediate the pharmacological actions of ligand. So I told you already, the receptors are binding sites. The binding substance is a ligand. When the ligand binds to the receptors, the ligand produces pharmacological actions. Am I right? This is the common agenda. Try to understand. This is the common agenda for everything. The ligand binds to the receptors. The ligand produces pharmacological actions. But how this ligand produces pharmacological actions is different. That only we have to study and understand. How the ligand produces pharmacological actions is different from one to others. That only we have to understand, we have to know actually. See what happened here? The first ligand bind to the receptors. So whenever the ligand bind to the receptors, what happened? I told you the G protein GDP will be there. This GDP replaces with the GTP. So means the guanosine diphosphate replaces with guanosine triphosphate. So GDP diphosphate, GDP triphosphate means the lower energy was replaced with higher energy. Because of this high energy, the G protein dissociated and break down into 2 complexes. So as I told you, so GDP replaces with GTP. So in the G protein, what we have? G protein is having 3 subunits, alpha, beta, gamma. This G stands for GDP before I told you. But here the GDP replaces with GTP. So because of the higher energy, this G protein undergoes dissociation and releases 2 complexes like GTP alpha, another one is beta gamma. So GTP alpha, another one is beta gamma. So now out of this complex is more active. GTP alpha complex is more active. This complex will interact with the pathways inside the cell and releases some substances which are called as secondary messengers. And these secondary messengers are responsible for mediating the pharmacological actions. So try to understand. In case of G protein coupled receptors, first ligand attaches to the receptors. As soon as ligand attaches to the receptors, the GDP replaces with GTP. Immediately, the G protein break down into two complexes like GTP alpha and beta gamma. So where the GTP alpha interacts with the pathways and releases some substances inside the cell called as secondary messengers, and those secondary messengers are producing pharmacological actions. This is how the ligands produce pharmacological actions in case of G protein coupled receptors. So why it is called as a secondary messenger is something is called as a primary messenger. Am I right? This is called as a secondary messenger means something is called as primary messenger. So what is that primary messenger is nothing but ligand. The primary messenger, the primary signaling molecule to the receptor is ligand. This ligand will initiate the release of some other substances. They are called as secondary substances, called as secondary messengers. Always these secondary messengers are responsible for mediating the pharmacological actions. So blindly you can say that the ligands produce pharmacological actions by releasing second messengers in case of G protein coupled receptors. Then finally what we have to know, still if you want to further know about the G protein coupled receptors, so we have to know what are the pathways we have and what are the secondary messengers we have and what are their pharmacological actions. Am I right? So the common agenda of G protein coupled receptors we understood, we know, we discussed. And finally, still, ligand produces what type of pharmacological actions if you want to know, what information you have to know, what pathways you have, and what are those second messengers and what are their pharmacological actions. All right. So usually, we have two pathways. What are those? We'll see one by one. See one of the representation. See here. This is the cell membrane. The receptor is located across the cell membrane. See, look onto this. Hence, these receptors are called as transcellular receptors. So try to understand. They're located across the cell membrane. So what happened? Ligand bind to the receptors. The GDP replaces with GTP. Dissociation will happen. So GTP alpha is more active. This GTP alpha interacts with pathways, releases second messengers, produces pharmacological actions. Now our duty is, see another representation, you concentrate only this. Agonist or ligand binds, activation of G protein, release of second messengers, producing the pharmacological actions. Now our duty is to know about pathways. How many pathways are present? What are the second messengers present there? And what are their pharmacological actions? So usually we have two pathways. So one such pathway is adenyl cyclase pathway. So what is the role of this adenyl cyclase pathway is, if the GTP alpha interacts with adenyl cyclase pathway, the role of adenyl cyclase is conversion of ATP to cyclic AMP. From the name itself, the pathway is mediated by the enzyme cyclase. The enzyme causes cyclization, which converts ATP into cyclic AMP. So in this pathway, the second messenger is nothing but your cyclic AMP. So got my point. The ligand bind to the receptors, GDP replaces with GTP, GTP alpha interacts with pathways. If it interacts with adenyl cyclase pathway, it releases cyclic AMP. This cyclic AMP will act as a second messenger. And this cyclic AMP will produce the pharmacological actions. And after actions, the cyclic AMP is inactivated by the enzyme phosphodiesterase. The enzyme phosphodiesterase is always involved in the inactivation of cyclic AMP after producing its pharmacological actions. See here, one such representation. Same G protein couple receptors, ligand binds, G protein dissociation. Now we have GTP alpha. This GTP alpha interacts with adenyl cyclists, converts ATP to cyclic AMP. This cyclic AMP is a second messenger, produces pharmacological actions. Am I right? Binding of ligand, dissociation of G protein, interaction of GTP alpha with adenyl cyclists, conversion of ATP to cyclic AMP. This is a second messenger. This produces pharmacological actions. What are those actions of cyclic AMP? So what are those actions of cyclic AMP? See, if you look onto the actions of cyclic AMP, the actions of cyclic AMP is different from one location to other location. So in case of cardiac muscle heart, the cyclic AMP will have contraction property. This is very important. Cyclic AMP is always responsible for contraction of heart, contraction of cardiac muscle. It causes increase in the force of contraction, increase in cardiac output, increase in blood pressure, increase in heart rate. Cyclic AMP will have increase in all parameters. It causes contraction. Basically, it increases force of contraction, increases cardiac output, increases blood pressure, increases heart rate. This is very, very important. Please remember. And the actions of cyclic AMP in smooth muscles. It causes smooth muscle relaxation. This is very important. In heart, it causes contraction because of phosphorylation of actin-myosin light chain. In smooth muscles, it causes relaxation due to dephosphorylation of actin-myosin light chain. It's different and very important. Don't confuse. In the heart, cyclic contraction. In the smooth, cause relaxation. Examples of smooth muscles are like bronchi, uterus. So GIT means every part of GIT means stomach, small intestine, large intestine. So small intestine means once again duodenum, jejunum, ileum, every part of GIT, smooth muscle. In all smooth muscles, cyclic AMP produces relaxation. And in the liver, cyclic AMP causes glycogenolysis. So means breakdown of glycogen to glucose. And in the adipose tissue, it causes lipolysis. And in the platelets, it decreases platelet aggregation. So got my point? As per the location, according to the location, the actions of cyclic AMP is going to vary. These are all very important to understand the actions of ligand and some drugs. In the heart causes contraction, in smooth muscles relaxation, in the liver glycogenolysis means breakdown of glycogen to give glucose. In the adipose tissue causes lipolysis, and in the platelets it decreases platelet aggregation. And move on to the another pathway, phospholipase pathway. This is another pathway. If the GTP alpha interacts with this pathway, if this pathway interacts and stimulates this phospholipase pathway, what happened is the stimulation of this pathway results in the breakdown of phospholipids, means cell membrane phospholipids. So these cell membrane phospholipids upon breakdown will give the two substances called as Ip3 and Dac, which are inositol 1,4,5 triphosphate and diacylglycerol. And these two will act as second messengers. See, if you stimulate this pathway, this stimulation of this pathway results in the breakdown of cell membrane phospholipids. The cell membrane phospholipids upon breakdown will give the two substances called as inositol 1,4,5 triphosphate and diacylglycerol, shortly called as Ip3 and Dac, and these two will act as second messengers. So mean to say that the GTP alpha complex interacts with the pathways. It may interact with adenyl cyclase pathway, it may interact with phospholipase pathway. If it interacts with adenyl cyclase pathway, second messenger is cyclic AMP. If it interacts with phospholipase pathway, second messengers are Ip3 and Dac. So try to understand that any one pathway only will come. Either it interacts with adenyl cyclase or it interacts with phospholipase. If it interacts with adenyl cyclase pathway, we have a release of second messenger called as cyclic AMP. If it interacts with phospholipase pathway, we have a second messenger called as Ip3 and Dac. And what are the actions of Ip3 and Dac is, the Ip3 and Dac always produce stimulation. So Ip3 and Dac always produce stimulation. So now, what are the actions of Ip3 and Dac is? So I told you already, the Ip3 and Dac always produce stimulation. Stimulation means what? In the cardiac muscles, contraction. In the smooth muscles, also contraction. In the skeletal muscles, also contraction. Means in the all muscles, stimulation means what? Contraction. Next, in the glands, increase in secretions. In the CNS stimulation. So try to understand, there is a little bit difference between cyclic AMP and Ip3 Dac. Cyclic AMP in the heart causes contraction, in the smooth muscles cause relaxation. This is quite opposite. And other locations. But Ip3 Dac in all the locations produce stimulation. Means in all the muscles, cardiac muscle, smooth muscle, skeletal muscle, they produce contraction. And in the glands, stimulation means what? Increase in secretions. And in the CNS, it causes CNS stimulation. Am I right? So this is why try to understand. So overall, what you have to understand is, if a ligand binds to the G protein coupled receptors, the GTP replaces with GTP, undergoes dissociation, that GTP alpha interacts with pathways. As a result, it releases some second messengers. Those second messengers will produce pharmacological actions. Here, there are two pathways by which the GTP alpha will interact is, it may interact with adenyl cyclase pathway or it may interact with phospholipase pathway. If it interacts with adenyl cyclase pathway, we have a second messenger called as cyclic AMP. If it interacts with phospholipase pathway, we have second messengers called as Ip3 and Dac. The actions of cyclic AMP we discuss. In the heart causes contraction, in the smooth muscles relaxation, in the liver glycogenolysis, in the adipose tissue lipolysis, in the platelets it decreases platelet aggregation. Coming to the actions of Ip3 Dac, in all the locations it produces stimulation. In all the muscles like skeletal, cardiac, smooth muscles causes contraction. And in the glands it increases secretions. And in the CNS it causes CNS stimulation. Finally, we have to conclude that all G protein coupled receptors mediate their pharmacological actions by releasing second messengers. But the type of second messenger is different. Am I right? That type of second messenger will be identified by some representations like GS, GI, GQ. So mean to say that I am telling that one receptor is a G protein coupled receptor. Immediately you have to understand that the receptor mediates the pharmacological actions through second messengers. But which second messenger? Which second messenger? That which second messenger, the type of second messenger will be identified by the three symbolic representations GS, GI, GQ. GS means increased levels of cyclic AMP. Means if any one receptor is a GS type, that means actions are mediated through increased levels of cyclic AMP. GI, decreased levels of cyclic AMP. GQ, increased levels of Ip3 and Dac. So based upon these representations, we can understand that the receptor is mediating the actions through which second messenger. I'm repeating. GS, increased levels of cyclic AMP. GI, decreased levels of cyclic AMP. GQ, increased levels of Ip3 and Dac. From these symbolic representations, we can identify which second messenger is mediating the pharmacological actions. Clear? So coming to the examples. So what are the examples for all these G protein coupled receptors is muscarinic receptors from M1 to M5, adrenergic receptors alpha 1 to alpha 2 as well as beta 1 to beta 3, histamine receptors from H1 to H3, so dopamine receptors from D1 to D5, 5-HT serotonin receptors 5-HT1 to 7, all are G protein except 5-HT3. Then opioid receptors, GABA B receptors. So these are all the examples of G protein coupled receptors. Have a look onto this. Muscarinic receptors, all muscarinic receptors, all adrenergic receptors, all histamine receptors, all dopamine receptors, all 5-HT receptors except 5-HT3, all opioid receptors and GABA B receptors. So in the beginning itself, I told you, every receptor will have its own specific ligand. The nomenclature of receptors is based upon the name of the ligand. Am I right? So receptor will be there. To the receptor, the selective ligand will be there. The nomenclature of receptors is based upon the name of the ligand. So as per our earlier discussion, can you know what are the ligands for these receptors? Just if you have a paper, you write it on this. What are the ligands for these receptors? So muscarinic receptors means, in the beginning I told you, muscarinic receptors and nicotinic receptors are both are cholinergic receptors. So based upon the name, what will be the ligand for these receptors? Just 1 second. I mean, you write it on your paper. What are the ligands for these receptors? So what is the ligand for these muscarinic receptors? Acetylcholine. Am I right? What is the ligand for adrenergic receptors? Noradrenaline. For this, histamine. For this, dopamine. For this, serotonin. For this, opioid peptides inside the body. For this, GABA. Means how all these ligands will produce their pharmacological actions, I mean physiological actions, by binding to these receptors. So all these receptors are G protein coupled receptors. They are mediating their actions through release of second messengers. See, acetylcholine bind to the muscarinic receptors and produces pharmacological actions. How acetylcholine produces pharmacological actions? By binding to muscarinic receptors. What are muscarinic receptors which are G protein coupled receptors? How G protein coupled receptors mediate their pharmacological actions through release of second messengers. So now, what we have to know, if you want to know the pharmacological actions of ligand, acetylcholine, so we have to know that what is the second messenger. The type of second messenger known by, I told you, GS, GI, GQ. GS means increase levels of cyclic Mp. GI means decrease levels of cyclic Mp. GQ means increase levels of Ip3 and Dac. Now if you see, for your better understanding still, I will give some of the examples. I will explain with 2 examples, muscarinic receptors and adrenergic receptors. So if you see muscarinic receptors, what I told you, there are 5 muscarinic receptors M1 to M5. These M1, M3, M5, all these receptors are GQ type. These M2 and M4 receptors are GI type. So got it now? What is the ligand for muscarinic receptors? Acetylcholine. And all are G protein coupled receptors through second messengers. Which second messenger? That I am telling here. Muscarinic receptors with odd number M1, M3, M5. These three are GQ type. Muscarinic receptors with even number M2 and M4 or GI type. Now you see here, I'm giving the information that the receptor, what is the second messenger, and what is the location of receptors. Based on this, can you write the pharmacological actions here? See, the pharmacological actions of what? Ligand. The ligand for all these receptors is what? Acetylcholine. So when acetylcholine binds to the M1 receptors, it releases a second messenger. What is the second messenger? GQ. GQ means what? Ip3 and Dac. It produces actions where these receptors are located in these locations. So now what will be the pharmacological actions will come? If you see the location here, M1 receptors are located in gastric parietal cells. M1 receptors are located in ciliary muscles of iris. Same thing, M3 receptors are located in smooth muscles like bronchi, uterus, GIT. Glands like all sweat glands, salivary glands, lacrimal glands. And M5 receptors are located in CNS. So this is the location and distribution of receptors in the body, M1, M3, M5. All M1, M3, M5 are GQ. GQ means what I told you. GQ means increase the levels of Ip3 Dac. If Ip3 Dac increases, what are the pharmacological actions? Ip3 Dac, I told you, they always produce stimulation. They always produce stimulation. So all muscles contraction, glands increase in secretion, CNS stimulation. In all the locations, Ip3 Dac always produce stimulation. So based on this, can you write the pharmacological actions here? Can you try in your paper, at least for 1 minute just? I'm giving the second messenger to you. Ip3 Dac always produce stimulation. And I'm giving the location, the parietal cells present in stomach. Their actual role is release of acid. Ciliary muscles of iris in the eye, smooth muscles, glands, CNS. GQ, increase in Ip3 Dac, always produce stimulation. So based on this, what will be the actions will be observed here? Try for just 1 minute. Yeah. See now, what are the actions will come? So GQ means increase Ip3 Dac. So stimulation. So parietal cells. Stimulation of parietal cells means? So I told you the original function of parietal cells present in stomach, they are releasing acid. So the action is increase in acid secretion. Muscles, all muscles will undergo contraction. Contraction of ciliary muscles of iris leads to meiosis, decrease in the pupil size. Smooth muscle contraction like bronchoconstriction, constriction of uterus, constriction of GIT, as well as increase in the motility of GIT. So all glandular secretions will increase. Sweating, salivation, and lacrimation. And causes CNS stimulation. So got it now? So based on this location, see increase in acid secretion, meiosis pupil size, decrease in pupil size, smooth muscle contraction like bronchoconstriction, uterus constriction, GIT constriction, increase in all your glandular secretions, and CNS stimulation. So coming to the same thing, muscarinic receptors with even number. So muscarinic receptors with even number. M2 and M4. Both receptors are GI type. So location is M2 receptors are located in heart. M2 receptors are located in heart. M4 receptors are located in CNS. So based on this, can you tell me what type of pharmacological actions will come once again here? So GI means what? Decreased levels of cyclic AMP. GI means decreased levels of cyclic AMP. Can you try here? What are the actions will come? So GI, second messenger, decreased levels of cyclic AMP. So when acetylcholine binds here, decreases cyclic AMP in the heart. As a result, what actions will come? Can you try it? Can you write in a paper? Yeah. See here. So as a result, decrease in cyclic AMP. I told you, if cyclic AMP actual action is what? Increase in the force of contraction in the heart, increase in cardiac output, increase in blood pressure, increase in heart rate. But GI means what? Decrease levels of cyclic AMP. So if cyclic AMP decreases, what action will come? Decrease in force of contraction, decrease in cardiac output, decrease in blood pressure, decrease in heart rate. So got my point. So all the parameters will be decreases by acetylcholine because of decreased cyclic AMP. And if you come into the CNS, I told you GI decreases level of cyclic AMP. The cyclic AMP will not have much effect and influence on the CNS. That's why we can say there's no action. So now a representation once again here. So M1, M3, M5, muscarinic with odd number stimulates phospholipase pathway, GQ. So increases Ip3 and Dac. See positive. So always produce excitation. M2 and M4, muscarinic with even number, GI, inhibits adenylyl cyclase, decreases cyclic AMP, causes inhibition. Okay, so M1, M3, M5 or excitatory type. The second messengers are Ip3 and Dac, GQ type. M2 and M4 or inhibition type, GI type, inhibition of adenylyl cyclase. So this is a broad representation about your pharmacological actions of acetylcholine. So I told you, so as per the location, if you see, heart, decrease in force of contraction, decrease in cardiac output, decrease in blood pressure, decrease in heart rate. Smooth muscles, all smooth muscles will undergo contraction like bronchoconstriction, uterus constriction, GIT constriction, increase in the motility of GIT. In the gastric parietal cells, it increases acid secretion. In the eye, ciliary muscles of iris, constriction leads to meiosis, decrease in pupil size. In all the glands, glandular secretions will increase like salivation, sweating, and lacrimation. And in the CNS, it causes CNS stimulation. So this is a way to understand about G protein coupled receptors. One representation, one example I given to you, how to understand about G protein coupled receptors. So all G protein coupled receptors mediate their pharmacological actions through release of second messengers. So we have to identify the receptor is mediating actions through which second messenger. Either it is a GS type or GI type or GQ type. So GS means increased cyclic AMP, GI means decreased cyclic AMP, GQ means increase in Ip3 Dac. So and where the receptor is located, based on that we can write the pharmacological actions. See, we all know that you might have studied in your textbooks already pharmacological actions of acetylcholine in ANS so many times, but you will just simply by heart the things. But here, how in a cellular level, in a molecular level, the ligands are producing their pharmacological actions. That is very, very important. In what way acetylcholine decreases force of contraction? In what way acetylcholine decreases secretions? Likewise, we have to think and understand the molecular level action. If you see three-dimensional, in a 3D, you can think it of. For your understanding, I'm telling you. I told you M3 receptors or GQ means increased Ip3 and DAZ. Just think in a three-dimensional way. Assume it. M3 receptors are located in bronchi. Just assume it, one location. M3 receptors are located in bronchi. Now, what is the ligand for M3 receptors? Acetylcholine. M3 receptors are what? G protein coupled receptors. Means where the receptors are coupled to G protein. What is the location? Transcellular, across the cell membrane. First, acetylcholine releases. Then acetylcholine binds to M3 receptors. When acetylcholine binds to M3 receptors, what happened? G protein coupled. So, GDP replaces with GTP. Then, dissociation. What is a complex? GTP alpha interacts with pathway. Which pathway here? Which is a GQ. So, it interacts with what? Phospholipase pathway. So, GQ. So, it increases IP3-DAZ. It increases IP3 and DAZ in the bronchi. So, it causes bronchoconstriction because IP3 and DAZ always produce stimulation. Got it now? Likewise, you have to understand. Even if you see here also, M2 receptors. Let us consider release of acetylcholine binds to M2 receptors located in heart, GI type. So inhibits adenylyl cyclase, decreases cyclic Mp. So decreases cyclic Mp in heart causes decrease in force of contraction, decrease in cardiac output like this. So this is the way to understand. See, all the G protein coupled receptors are located on the cell membrane, transcellular receptors. Whenever the ligands will bind, GDP replaces with GTP. That undergoes dissociation. GTP alpha interacts with pathways which releases second messengers. Those second messengers will produce pharmacological actions. Our duty is we have to know where the receptor is located and what is the second messenger. So what is the second messenger will be understood by whether it is a GS type or GI type or GQ type. So in the same way, so we have adrenergic receptors. Clear? So what are those? Alpha and beta. Alpha 1 to alpha 2 as well as beta 1 to beta 3. Am I right? So if you have then adrenergic receptors. So what is the ligand for adrenergic receptors? Noradrenaline. What are the receptors for adrenergic receptors? Alpha and beta. Alpha 1 to alpha 2 as well as beta 1 to beta 3. So now you see what is the second messenger here. For alpha 1, second messenger is GQ. For alpha 2, which is a GI. For all beta receptors, it is GS. Alpha 1, which is a GQ, increase in IP3-DAZ. Alpha 2, which is a GI, decreases cyclic AMP. All beta receptors are GS, nothing but increased cyclic AMP. Now, are you able to write the actions now? If you are able to write, that will be the actions of noradrenaline. See, I'm giving you the type of receptor, the second messenger, and the location. Will you predict the pharmacological actions here? So try for 30 seconds. See, GQ means increase in IP3-DAZ. Increase in IP3-DAZ means always stimulation. Means here blood vessels. Stimulation means what? Vasoconstriction. So because of vasoconstriction, blood pressure will be increases. Am I right? Alpha 2 is GI. CNS. I told you cyclic AMP will not have much influence on the CNS. You can say there is no action. And some books are referring to the CNS depression. Same thing. All beta receptors are GS type. Beta 1, beta 2, beta 3. GS type. GS means increased levels of cyclic AMP. Increased levels of cyclic AMP. So beta 1, as we all know that location is hot. Beta 2, smooth muscles, especially in bronchi liver. Beta 3 as well as in adipose tissue. So we know that GS means increased cyclic AMP. We know already what are the actions of cyclic AMP and what is the location of receptors. Will you predict the pharmacological actions here mediated through all these beta receptors? Just try, just 30 seconds to 1 minute, you try it. If you are able to write means you can understand entirely about the receptors, the pharmacology almost you can understand. GS means increase the cyclic AMP. Already we discussed what are the actions of cyclic AMP and these are the locations. If noradrenaline binds to these receptors, the cyclic AMP levels will increase. Based upon that, the actions will result here. Yeah. Now, so hot. So what are the actions will come here? Increase in force of contraction, increase cyclic AMP, right? So increase in cardiac output, increase in blood pressure, increase in heart rate. GS, increase cyclic AMP, smooth muscle relaxation. I told you already, cyclic AMP is very, very important. In the heart, it causes contraction. In the smooth muscles, it causes relaxation. So bronchodilation. In the liver, glycogenolysis. And in adipose tissue, it causes lipolysis. Because of increased cyclic AMP, it increases force of contraction, cardiac output, blood pressure, heart rate, smooth muscle relaxation, bronchodilation, glycogenolysis, and lipolysis. What are all these actions? These are all the actions of ligand. What is the ligand? Noradrenaline. So these are all the pharmacological actions of noradrenaline, which is mediated through these beta receptors. Finally, have a look onto these pharmacological actions of noradrenaline. In the heart, increase in force of contraction, increase in cardiac output, increase in blood pressure, increase in heart rate. In the smooth muscles, it causes smooth muscle relaxation, bronchodilation. In the blood vessels, vasoconstriction as well as increase in blood pressure. Metabolic effects include glycogenolysis and lipolysis. So this is the way to understand all G protein coupled receptors, by which you can understand the actions of so many ligands. So once again, in a three-dimensional way, you understand, please. You consider this beta 1, GS. So try to understand the beta 1 receptors are located in heart. What are beta 1 receptors? Beta 1 receptors are G protein coupled receptors. Means located on the cell membrane. Means they are coupled to G protein. Release of ligand. What is the ligand for beta 1? Noradrenaline. So noradrenaline release takes place. So noradrenaline binds to beta 1 receptors. Immediately GDP replaces with GTP, undergoes dissociation. Their active complex is GTP alpha. That GTP alpha interacts with the pathways. Which pathway now? GS. It interacts with adenyl cyclase, stimulates adenyl cyclase. So due to stimulation of adenyl cyclase, increases cyclic AMP in the heart. Because of increased cyclic AMP in heart, it increases force of contraction, increase in cardiac output, increase in blood pressure, increase in heart rate. This is a three-dimensional way you have to understand. So ligands will release in the body. They are binding to the receptors. If it is a G protein dissociation interacts with pathways, releases second messengers. Those second messengers will produce the pharmacological actions based on their location. So this is the way to understand about all G protein coupled receptors. So just please have a look onto this G protein coupled receptors for 1 minute. So likewise, you just see this once again. Cell membrane, transcellular, ligand binds, dissociation, interaction with pathways, release of second messages. Just have a look onto this and revise the things. Just for 1 minute, I will come back. So just look onto this, how the G protein coupled receptors, you read back the things, what we discussed, what is happening in the G protein coupled receptors, everything. Then we'll move on to the ionotropic receptors. If you are clear with these concepts, we'll move on to the second type of receptor, because G protein coupled receptors is a very, very important type of receptors. Most of the receptors in pharmacology belonging to this type only. Just have a look at this just for 1 minute. Move on to the next. Ionotropic receptors. See here. So after this G protein coupled receptors, the another major receptors in pharmacology is ionotropic receptors. So from the name itself, you can understand, I already told you, the receptors coupled to ion channels. I'm right here. So previously, the receptors coupled to G protein. Now, the receptors coupled to ion channels, which are called as ionotropic receptors. So coming to the location of these receptors also located on the cell membrane, hence which are also called as transcellular receptors. So got my point. All these ionotropic receptors are located across the cell membrane, so like G protein coupled receptors, hence which are also called as transcellular receptors. And these receptors are also called as ligand-gated ion channels. What is this? Ligand-gated ion channels. Now you see here, what is the sequence of events taking place in producing the pharmacological actions? So I already told you, the starting is ligand bind to the receptors. The ending is what? Ligand produces pharmacological actions. How the ligand produces pharmacological actions is different from one kind to another kind I have discussed with you. So here also what happened is, in the case of ionotropic receptors, the ligand binds to the receptors. So when the ligand binds to the receptors here, the ion channels will get open. The opening of ion channels will take place. So whenever these ion channels will open, what happened? That result in either influx or efflux of ions. That depends upon the concentration gradient. And this influx or efflux of ions is responsible for mediating the pharmacological actions. So got it here. So common thing is, I told you already, the receptors are proteins, they are binding sites. The binding substance is a ligand. When the ligand binds to the receptors, it produces pharmacological actions. How ligand produces pharmacological actions is somewhat different. In the G protein, we discussed by releasing second messengers. But here, if the ligand binds to the receptors, the ion channels will be get opened. So due to opening of ion channels, which causes either influx or efflux of ions, that depends upon the concentration gradient. And that influx of efflux of ions is responsible for pharmacological actions. So have a look on this once again. What is exactly mean by this? So it is one representation once again. So this is like once again cell membrane. The receptors are located on the cell membrane, across the cell membrane, called as transcellular receptors. So here the ligand binds. So before the binding of ligand, see, this is a closer conformation. So when the ligand binds here, the influx of ions or anything, efflux of ions, depends upon the concentration gradient. So which are closed before binding of ligand. So when the ligand binds, they will be in the open state. So coming to this, which ions will undergo influx, which ions will undergo efflux? We told influx or efflux depends upon the concentration gradient. How it will happen is the sodium, calcium, and chloride ions, they are always present extracellularly. High concentrations of these ions are present extracellularly. So that the opening of these ion channels will always result in the influx. Keep in mind, if you consider the cell, the sodium, calcium, and chloride ions always present extracellularly. High concentrations, I'm speaking of this. The high concentrations of sodium, calcium, chloride are present extracellular. So whenever these ion channels get opened, the possibility is influx of ions. The high concentrations of potassium ions are present intracellularly. So the possibility is efflux of ions. So got it now? So always remember, whenever sodium, calcium, chloride channels get open, that leads to influx. Whenever the potassium channels get open, that leads to efflux. This is a common. This is not going to change anyway. The opening of sodium channels causes influx. The opening of calcium channels causes influx. The opening of chloride channels causes influx. The opening of potassium channels will cause efflux. Finally coming to this. Now what we told? So ligand bind to the receptors. If it is, suppose, what I told you, the ionotropic receptor means the receptor is attached to ion channels, to any of the ion channels. So which may be attached to sodium channels or calcium channels or chloride channels or potassium channels. What will happen if the receptors are attached to different types of these ion channels? We will see here. Once again say, the receptor is ionotropic receptor. The receptor is attached to ion channel. The receptor is attached to any one of the ion channel. Like our G protein, the receptors mediate reactions through second messenger, any one second messenger, either GS or GI or GQ. In the same way here also, the receptor is attached to any one of the ion channel, like sodium or calcium channel or chloride channel or potassium channel. What happens if they are attached to different types of ion channels? I'm explaining here. Suppose if the receptor is attached to sodium channels, what will happen? The ligand bind to the receptors. If it is attached to sodium channels, that causes influx of sodium ions. Am I right? Calcium, influx of calcium. Chloride, influx of chloride. Potassium, efflux of potassium. So that influx or efflux of ions is responsible for pharmacological actions we told. So what are the pharmacological actions will come? Tell me. Just for 30 seconds you think it up. So always pharmacological actions are either in two types, stimulation type or inhibition type. See, ligand bind to the receptors, ion channels are open, influx or efflux depends upon concentration gradient. I told you which will undergo influx, which will undergo efflux. Now finally our duty is to know pharmacological actions. So pharmacological actions are always broadly stimulation or inhibition. Can you tell me what type of actions will come? Stimulation or inhibition? If it is attached to sodium, what? Calcium, chloride, potassium. Can you write it on your paper? So we know that sodium carries positive charge. Influx of sodium, the positively charged ions enter into the cell. I'm giving one example. Automatically when the positively charged sodium ions will enter into the cell, cell potential increases, cell will undergo stimulation. Am I right? When the receptor is attached to sodium channels, when the ligand binds, the sodium channels get opened, the sodium ions will undergo influx. The influx of sodium means influx of positively charged sodium ions. When the positively charged sodium ions will enter into the cell potential will increase. Automatically it causes cell stimulation, means stimulatory actions will observe. Likewise, can you write it for this? Influx of calcium. Calcium also carries positive charge. Influx of chloride. Chloride carries negative charge. Efflux of potassium. See, try to understand. Potassium carries positive charge, but it undergoes efflux. So now the resultant effects are like this. If it is attached to sodium channels, stimulation, because positively charged sodium enter into the cell. Calcium ions, the positively charged calcium enter into the cell. Influx of chloride, the negatively charged chloride enter into the cell. Negative enters, inhibition. Efflux of potassium, see, positive this is, but it undergoes efflux. When the positive potassium enter outside, automatically cell potential decreases. It leads to inhibition. So likewise, you have to understand all these pharmacological actions. So once again, stimulation inhibition means what? That stimulation inhibition depends upon the location. Am I right? So as I discussed, so cardiac muscle stimulation means contraction. In any muscles, stimulation means contraction. Inhibition means relaxation. In glands, stimulation means increase in secretions. Here, decrease in secretions. In CNS, stimulation means CNS stimulation. In inhibition means CNS depression. So here what we have to know, in ionotropic receptors, we have to see the receptor is located in which location and the receptor is attached to which type of ion channel. In the G protein coupled receptors, we see the receptor is located in which place and what is the second messenger. Am I right? By knowing the second messenger, by knowing the location, you are writing pharmacological actions. Here what? We have to know the receptor is located where and what is the ion channel attached. So based upon the type of ion channel attached and based upon the location, we can write the pharmacological actions. Am I right? See, some such examples are for ionotropic receptors. I told you already, most of the receptors in pharmacology belonging to G protein. Some receptors are ionotropic, which include like nicotinic receptors. Some exemptions will be there, right? In the G protein, I told you. In the G protein, some exemptions I mentioned. What is this? Cholinergic include two, muscarinic and nicotinic. Muscarinic receptors are G protein, so nicotinic receptors will come under ionotropic. All 5-HT receptors are G protein except 5-HT3. GABA P receptors here. This is G protein. So whatever exemptions will be there here, that will come under ionotropic receptors here. Like nicotinic receptors, both NM and NN, 5-HT3 receptors, GABA A receptors, as well as NMDA receptors. So once I told you, every receptor will have its own ligand. Based upon the name of the ligand, we are giving name to the receptors. Can you write some ligand on these receptors? What is the ligand for nicotinic receptors, 5-HT receptors, GABA A receptors, NMDA receptors? So once and same, nicotinic receptors are part of cholinergic receptors. So ligand is acetylcholine. For this, serotonin. For this, GABA. For this, NMDA. N-methyl D-aspartate. Aspartate, N-methyl D-aspartate. These are all the ligands for these receptors. Now, can you try the pharmacological actions? Now, I will give you so location as well as the type of ion channel attached. Based upon this, will you try pharmacological actions on your book? So you take your paper and you try to write the pharmacological actions here. I'm giving all the information to you. These nicotinic 5-HT3 GABA A NMDA receptors are ionotropic receptors attached to ion channels. Which ion channels they are attached, I given the information, and where they are located also I'm mentioning here. Based on this information, will you try to write the actions here? So NM attached to sodium channels, location is skeletal muscles. NN receptors attached to sodium channels located in autonomic ganglia. 5-HT3 receptors are located in CTZ attached to sodium channels. GABA-A receptors are attached to CNS, attached to chloride channels. NMDA receptors are located in CNS, attached to calcium channels. Will you write the pharmacological action? Just try for 30 seconds. What actions will come here? Yeah. So now, skeletal muscles. Sodium. So it causes influx of sodium, stimulation. So skeletal muscle contraction. Sodium, influx of sodium causes stimulation. So ganglionic stimulation. So once I said influx of sodium stimulation, stimulation of CTZ causes nausea and vomiting. Chloride, influx of chloride causes inhibition. So CNS depression. Calcium, influx of calcium causes stimulation, produces CNS stimulation. So this is how you understand the pharmacological actions of ligands. So what is the ligand for this? Acetylcholine. So acetylcholine actions are skeletal muscle contraction, ganglionic stimulation. The role of serotonin involved in the pathogenesis of nausea and vomiting. The action of GABA is CNS depression. The action of aspartate glutamate, CNS stimulation. So based on this, will you develop the drugs? Will you develop the mechanisms? I already told you that every drug in pharmacology is two types, either agonist or antagonist. Agonist produces actions similar to ligand. Antagonist will stop the actions of ligand. Agonist produces actions similar to ligand. Antagonist will stop the actions of ligand. Antagonist is otherwise called as blocker. So based upon your requirement, if you want ligand actions, you will go for agonist. If you want to stop the actions of ligand, you will go for antagonist. So based upon this, you see, skeletal muscle contraction is produced by acetylcholine. So basically, therapeutically, we have a use with skeletal muscle relaxants. So that we are developing blockers, NM receptor blockers. Likewise, NM receptor blockers, ganglionic blockers. So nausea, vomiting. So we don't want nausea, vomiting. We want to stop the vomiting. So that we are developing antiemetics. Mechanism is blockers, because we should stop it. Same thing, pharmacologically, therapeutically, we have a lot of use with CNS depressants. So that we are using GABA-A receptor agonists, NMDA receptor blockers. I'm telling that this is the action produced by the ligand. This is the action produced by the ligand. Based upon the action of the ligand, if you want the same action, we'll go for agonist. If you don't want, we'll go for antagonist. Based upon the clinical requirement, efficacy, so agonist or antagonist. Got my point? So we have much use with the skeletons during surgery to anesthetize the persons. So that we are developing skeletal muscle relaxants. For that mechanism is blockers. And clinically, pharmacologically, we have a lot of use with CNS depressants. I think you know that. CNS depressants are used as sedatives, hypnotics, general anesthetics to reduce anxiety, to produce sleep. So that we want CNS depressants. So for that, what is the mechanism we have to develop? For this GABA-A agonist. For this NMDA, we have to use NMDA blockers. Likewise, clinically, we have very much use with antiemetics, but not with the emetics. So that's why if you want to develop antiemetics, what is the mechanism we have to know? 5-3 blockers. So likewise, I'm telling that we have to know what is the ligand, what is the receptor, what is its action. Based upon the action of the ligand, clinically we can see if you want to require same action, we'll go for the development of agonist to the receptors. If you don't want the action, if you want to suppress the action, we'll go for the development of antagonist to these receptors. Fine. So this is once again about ionotropic receptors. So this is what about ionotropic receptors. So coming to the third type of receptors called as enzyme-linked receptors. So with this, we have completed about the two types of receptors like G protein coupled receptors and ionotropic receptors. So basically those two receptors are very important types, and almost 95% of receptors belong to this family, and those things only we have to know very much aware of that. And remaining two, enzyme-linked and nuclear receptors, is not that much. And anyway, we have to see definitely what will happen in these receptors also and how they are mediating the actions also. Same thing, if you see enzyme-linked receptors, same thing, receptors are coupled to enzymes. Am I right? Same thing, receptors are located across the cell membrane, like our G protein, like our ionotropic. So G protein, ionotropic, enzyme linked, all receptors are located on the cell membrane, across the cell membrane. Hence, all these three receptors are called as transcellular receptors. Now, same question. The ligand binds to the receptors. The ligand produces pharmacological actions. How it produces pharmacological actions? In G protein, how? In G protein couple receptors, ligand bind to the receptors. GDP replaces with GTP, undergoes dissociation, interaction with pathways, release of second messages. In ionotropic receptors, ligand bind to the receptors, ion channels will be opened, influx of ions or efflux of ions, producing pharmacological actions. In enzyme linked receptors, what is happening here? Ligand bind to the receptors. When the ligand bind to the receptors, the enzyme attached to the receptors will automatically undergo phosphorylation. And that autophosphorylation of enzyme is responsible for mediating pharmacological actions. Got it, Mike? So nothing else here. The receptors are directly attached to enzymes. When the ligand bind to the receptors, the enzyme attached to the receptor will automatically undergo phosphorylation. That autophosphorylation of enzymes is responsible for mediating the pharmacological actions. So nothing else, that's all. And like previously, the G protein coupled receptors mediate their actions through second messengers. We have different second messengers like GS, GI, GQ. Ionotropic receptors mediate their actions through opening of ion channels. We have different ion channels like sodium, calcium, potassium, chloride. But in the same way, enzyme linked receptors means the receptors are attached to different kind of enzymes, different varieties of enzymes. But the most of the enzyme linked receptors are coupled to the enzyme tyrosine kinase. That's why if you see some of the textbooks like Tripathi and all, they have not mentioned as enzyme linked receptors. They directly mention as tyrosine kinase linked receptors. So mean to say that you don't feel that always all the receptors are linked to tyrosine kinase. Most of the receptors are linked to tyrosine kinase. The concept is here, the receptors are attached to enzymes. The enzymes undergo autophosphorylation. That autophosphorylation of enzyme will bring the actions of ligand. So what are the examples for these enzyme linked receptors is like your insulin receptors. So I'm mentioning they are attached to which enzyme also, tyrosine kinase. Epidermal growth factor receptors attached to tyrosine kinase. Natriuretic peptide receptors attached to guanine cyclist. So what is the ligand? Once again, the ligand for this is insulin. The ligand for this is growth factor. The ligand for this is natriuretic peptide. So whenever the ligands bind here, these enzymes will undergo autophosphorylation. And these autophosphorylation of enzymes will bring the actions of these ligands. The action of insulin, we all know that decreases blood glucose levels. Growth factor for growth, natriuretic, like diuretic. Diuretic means which increases urine water output majorly. Natriuretic means majorly increases excretion of sodium, that's why Na. The diuretics which predominantly cause the excretion of sodium called as natriuretics. So finally coming to the fourth type of receptors, nuclear receptors. So where the receptors are directly coupled to nucleus. So previously they are attached to G protein, previously they are attached to ion channels, they are attached to enzymes. Now here the receptors are directly attached to nucleus. So they are attached to nucleus means you can expect easily where they are located. So they are located inside the cell. Hence these receptors are called as intracellular receptors. Got my point? This is the most important assumption you have to understand here. All the receptors discussed so far are transcellular receptors located across the cell membrane on the cell membrane. But the nuclear receptors are directly attached to nucleus located inside the cell, which are called as intracellular receptors. Except nuclear receptors, all receptors are transcellular receptors, but the nuclear receptors are intracellular receptors. And these nuclear receptors are also called as steroidal receptors because most of the steroidal hormones, steroidal drugs in our body will produce the action by binding to these nuclear receptors. And how the nuclear receptors mediate their pharmacological actions? Once again, I mean to say the physiological actions or whatever it is. Same thing. The common concept is what? The first step is binding of ligand. Last step is what? Producing the pharmacological actions. But how the ligand produces actions only we are studying always. In case of nuclear receptors, how ligand produces pharmacological actions, we'll see here. If the ligand binds to the receptors, as we discussed, the receptors are directly attached to nucleus. So whenever the ligand binds to the receptors, the nucleus, the genes, directly change their expression. So there is a direct change in the expression of genes. So because of that, there is a synthesis of specific mRNA, which causes the production of proteins. These proteins will produce the pharmacological actions. As you know that when the gene expression changes, transcription and translation, DNA to RNA, RNA to proteins. So whenever the ligand binds to the receptors, the gene coupled to the receptor, the DNA coupled to the receptors will automatically change its expression. So synthesizes its own mRNA, causes the synthesis of proteins, which will produce the pharmacological actions. Clear? So now here the ligand produces pharmacological actions directly by changing the gene expression. Unlike our receptors, it is completely different pattern. In the first case, G protein coupled receptors through release of second messengers. In the second case, through opening of ion channels. In the third case, autophosphorylation of enzymes. In the fourth case, due to change in the gene expression. See here, just one representation here for your understanding here. See now, nuclear receptors. See here, ligand. So ligand bind to these receptors. So when the ligand binds, what happens? See, this is receptors, right? Nuclear receptors attached to the nucleus. So when the ligand binds to the receptors, so gene expression changes. See DNA here, gene expression changes, causes mRNA, causes proteins, which produce the physiological actions, biological actions, pharmacological actions. So clear, binding of ligand, change in the expression of genes, DNA, synthesis of mRNA, production of proteins, producing the pharmacological action. So what are the examples for these nuclear receptors is, I told in the beginning itself, all the steroidal drugs, steroidal hormones in our body produce their actions through nuclear receptors. So those are like your glucocorticoid receptors, mineralocorticoid receptors, estrogen receptors, progesterone receptors, androgen receptors, vitamin A and vitamin D receptors, thyroid hormone receptors. I think these are all the steroidal drugs. I mean to say the steroidal hormones in our body. So every receptor will have a ligand inside our body. Ligand is endogenous. So what is the ligand here? What is the ligand for glucocorticoid receptors? Glucocorticoids. So what are examples of glucocorticoids? Like your cortisone, hydrocortisone. So like your drugs like dexamethasone, prednisolone. So mineralocorticoid, the ligand for mineralocorticoid receptors is what? Mineralocorticoid. The best example of only one mineralocorticoid is aldosterone. I think you have know that in the anatomic physiology, why they are named like this. Corticosteroids means steroids released from the cortex, adrenal cortex. Basically, these things are released from the adrenal gland. Adrenal gland will have two parts, adrenal medulla, adrenal cortex. The adrenal cortex releases some steroids which are called as corticosteroids. Whatever the corticosteroids will alter glucose metabolism called as glucocorticoids. Whatever the corticosteroids will alter mineral metabolism, fluid metabolism called as mineralocorticoids. That is nothing but your aldosterone. And all your sex hormones like estrogen, progesterone, testosterone are also steroids. They also produce their actions through these receptors called as estrogen receptors, progesterone receptors, androgen receptors. And some of the fat soluble vitamins A and D, which also look like steroids, they are having steroid structure. They also same thing. And finally, thyroid hormone receptors. And finally, this is the broad representation about 4 types of receptors. So have a look onto this. See, this is G protein coupled receptors. From this, you can understand about 4 types of receptors in a glance. So first, G protein coupled receptors. See, location is across the cell membrane. Agonist binds or ligand binds. I told you already, ligand and agonist both are same. Ligand is endogenous, agonist is exogenous. Both will produce actions in the same mode, same methodology, nothing else will be there. Whenever you have a ligand, we are taking agonist in the form of drug from outside. So agonist binds to G protein coupled receptors. Same thing. G protein activation means GDP replaces with GTP, releases second messengers, produces actions. Ionotropic receptors binds opening of ion channels, sodium, so that influx. That causes actions. So enzyme linked receptors are attached to enzymes. The binding of agonist, the enzymes gets phosphorylated, causes actions. The nuclear receptors, see here, these three are located on the cell membrane. Okay, this is the cell membrane, and across the cell membrane, called as transcellular receptors. If you see this receptor inside the cell, intracellular receptor, the agonist binds. So as usually, change in the nucleus, transcription and translation, which allow the pharmacological actions. So got it here. This is a comparison about 4 types of receptors. So this is another representation regarding these receptors. Same thing. See, here they clearly mentioned G protein coupled receptor. See, I told you 7 helical structures. See, 1, 2, 3, 4, 5, 6, 7. 7 helical structure. 3 loops, I told you. 1, 2, 3. See here. 1, 2, 3, 4, 5, 6, 7. 7 helical structure. 1, 2, 3. 3 loops. G protein. 3 subunits, alpha, beta, gamma, attached to GDP. So ligand binds. Ionotropic receptors is like ion channel. Enzyme linked receptors are coupled to enzymes. So this is all once again, see cell membrane. 1, 2, 3. These 3 are on the cell membrane, transcellular. And this is inside the cell. So have a look at this just for 30 seconds for your understanding. And coming to the word called as signal transduction. So there is a word we have to understand, signal transduction. The meaning of signal transduction is the ligand after binding to the receptors, some sequence of steps take place to produce pharmacological actions. So if it is a ligand, you can say that's physiological actions. If it is agonist, you can say that pharmacological actions. Okay, no problem. Biological actions for ligand or physiological actions. So ligand, after binding to the receptors, the meaning of signal transduction, I think you have seen the textbooks, transduction pathways, transduction mechanism, signal transduction. The meaning of signal transduction is the ligand, after binding to the receptors, some sequence of steps will take place to produce the actions that is called as signal transduction. Signal is nothing but here ligand. What is the signal for everything? Ligand. When the signal comes, when the ligand attaches to receptors, some sequence, some steps will take place to produce the actions. This is called as signal transduction. So what is signal transduction in G protein coupled receptors? Tell me, ligand after binding to receptors, I'm telling. Ligand after binding to receptors, some changes will happen to produce the actions. That is only we are studying here. So what is signal transduction in G protein coupled receptors? Once the ligand binds, GDP replaces with GTP, undergoes dissociation, interaction with pathways, release of second messengers. In case of ionotropic receptors, ligand binds means opening of ion channels, either influx or efflux of ions. If you take enzyme linked receptors, ligand binds, enzyme will undergo autophosphorylation. If the nuclear receptors, the ligand binds, the nucleus changes its expression, transcription, and translation. So based on this, what I'm telling is, can you say that what are the fastest acting receptors? And in which receptors you can observe most intensifying action? After binding of ligand, some sequence of steps will take place to produce the actions. I told you what happened in all the receptors. Based upon this, can you tell the fastest acting receptors? In which receptors will observe action very fast? In which receptors can observe most intensifying action? Means the action will be more intense, more severe. Is the fastest acting receptors are your ionotropic receptors. In these, we can observe action in a very milliseconds, the very faster rate. The most intensifying action observed for nuclear receptors, because the nuclear receptors action is directly because of change in the gene expression, not by second messengers, not by ion channels, not by enzymes, not by other some secondary mechanisms. Here, action is directly because of change in the gene expression. That's why we're telling that generally steroids, steroidal drugs are more potent, more efficacious, and more toxic also. So finally, we'll have a comparison between the transcellular receptors and intracellular receptors. Got my point? Finally, we have a comparison between the transcellular receptors and intracellular receptors. So I told you the transcellular receptors are 3 located around the cell membrane. So intracellular receptors are located inside the cell. On comparisons, or what is the thing you can just see here. The first parameter is ligand binding site. So what is the ligand binding site for transcellular receptors is where ligand is binding, and where ligand is binding here. So this is just where ligand is binding. And binding of ligand, some reactions are taking place. Where those reactions are taking place for transcellular and intracellular? And what are the examples? I'm asking about just intracellular or extracellular. So what is the ligand binding site? Intracellular or extracellular? Where the reactions are taking place, either intracellular or extracellular. See here, for transcellular receptors, the ligand binding site is absolutely extracellular. Am I right? Because they are located across the cell membrane. If you see this diagram, where the ligand is binding, extracellular, extracellular, extracellular. But here, intracellular. And where the reactions are taking place, intracellular. Am I right? So wherever the ligand is binding, in all the cases, reactions are inside. Here also reactions are inside. Dissociation rather. Here also inside. Here also inside. But everywhere, for all types of receptors, reaction should always take place in the intracellular level. But the ligand binding site is different, which is extracellular for transcellular and which is intracellular for intracellular receptors. And these are all the examples, like G protein, ionotropic enzymatic receptors are transcellular, and nuclear receptors are intracellular receptors. So got it now? So this is the overall comparison between all types of receptors. So once I'm concluding all these things, so within just 5 to 6 minutes, so whatever I discussed so far, just I would like to recall the things, so what is discussed right now, as of now. So with this, we have concluded and completed about the receptors topic, and I will revise the things. I will revise all the things within 5 minutes. After that, I will show you one video also regarding this topic, which will better give you some idea about these receptors. G protein receptors major. See, what I'm telling here is our body is made up of several proteins. Some proteins will act as binding site for drugs or ligands. Those proteins are called as ligands. Sorry, those proteins are called as receptors. Once again, I'm telling, our body is made up of several proteins. Some proteins will act as binding sites for ligands and drugs. Those are called as receptors. The substance that can selectively attach to the receptors is called as a ligand. Capacity to bind with the receptors is called as affinity. Capacity to activate the receptors called as intrinsic activity efficacy. So agonist is having affinity and maximum intrinsic activity. Antagonist is having only affinity but no intrinsic activity. This antagonist is otherwise called as blocker. Always you have to remember the drugs in pharmacology are of 2 types, either agonists or antagonists. So what are ligands is? Ligand is endogenous. The several neurotransmitters, chemicals released in our body will act as ligands. If you want the actions of ligand, we are using agonist. If you want to stop the actions of ligand, we are using antagonist. The only point you have to understand is drugs in pharmacology are 2 types, agonists or antagonists. When we are using drugs means you have some problem. You have some abnormality. So what is the reason for that abnormality? Something is happened abnormally inside the body. That is because of changes in our neurotransmitters or hormones or chemicals in the body.
Okay.
See, if our body is having several chemicals, neurotransmitters, hormones, if all are doing their function correctly, no disease will come, no disorder will come, no abnormality will come. But something is happened, some problem is happening means something is altered. Ligand increases or ligand decreases. Hence, you have some problem, so that you are using drugs, either agonists or antagonists. So always agonist and ligand both are same, but ligand is endogenous, agonist is exogenous. And antagonist also called as blocker, which will stop or blocking the actions of a ligand. So basically for this, we have to know 4 types of receptors. All receptors are not single, not alone. They are always coupled. To what they are coupled is different. Based on that, we are giving name to the receptors. If the receptors are coupled to G protein, they are called as G protein coupled receptors, where the actions are mediated through the release of second messengers. What happened, I told you, the ligand binds, GDP replaces with GTP, dissociation, interaction with pathways, release of second messengers produces actions. So how many pathways are there? 2 pathways, adenyl cyclase pathway, phospholipase pathway. What are the second messengers? GS, GI, GQ. Increase levels of cyclic Mp, decrease levels of cyclic Mp, increase levels of Ip3 and Dac. So for that, I given some representations regarding muscarinic and adrenergic, in what way you have tried the actions also. So based on this, I explained you pharmacological actions of acetylcholine and noradrenaline in a cellular molecular basis. So ionotropic receptors, they are attached to ion channels, where actions are mediated through opening of ion channels. When the ion channels get opened, that may lead to influx or efflux. Sodium, calcium chloride will undergo influx, potassium will undergo efflux. So based on this, you will get the actions also, like for sodium, calcium will get stimulation, for chloride and potassium will get inhibition. So enzyme linked receptors, they are always coupled to enzymes. Most of the receptors are coupled to tyrosine kinase. Whenever the ligand binds here, the enzyme automatically undergoes autophosphorylation. That autophosphorylation of enzyme is responsible for mediating the actions. So nuclear receptors, they are directly attached to nucleus, where the ligand binds, gene expression will change, transcription and translation, the proteins synthesized will produce the actions. So almost all the steroidal drugs, hormones produce their actions through nuclear receptors. So on comparison, this is what you can see here. This is what here. On comparison, based on the location, the receptors are 2 types, transcellular and intracellular. This is once again the comparison between the transcellular and intracellular. The transcellular receptors include 3, like G protein, ionotropic and enzyme link, and intracellular receptors include nuclear receptors. So with this, we have completed the part of pharmacodynamics, majorly about receptors. What are the importance of receptors, what is the significance of receptors, and how the receptors involved in mediating the actions of drugs as well as the ligand. So if you see here, just one video.
Sir. Yes, sir.
Many G-protein coupled receptors have a large extracellular ligand binding domain. When an appropriate protein ligand binds to this domain, the receptor undergoes a conformational change that is transmitted to its cytosolic regions, which now activate a trimeric GTP binding protein, or G protein for short. As the name implies, a trimeric G protein is composed of 3 protein subunits called alpha, beta, and gamma. Both the alpha and gamma subunits have covalently attached lipid tails that help anchor the G protein in the plasma membrane. In the absence of a signal, the alpha subunit has a GDP bound, and the G protein is inactive. In some cases, the inactive G protein is associated with the inactive receptor, while in other cases, as shown here, it only binds after the receptor is activated. In either case, an activated receptor induces a conformational change in the alpha subunit, causing the GDP to dissociate. GTP, which is abundant in the cytosol, can now readily bind in place of the GDP. GTP binding causes a further conformational change in the G protein, activating both the alpha subunit and beta-gamma complex. In some cases, as shown here, the activated alpha subunit dissociates from the activated beta-gamma complex, whereas in other cases, the two activated components stay together. In either case, both of the activated components can now regulate the activity of target proteins in the plasma membrane, as shown here for a GTP-bound alpha.
So clear here? So likewise, GTP alpha will be dissociated. It will bind with the pathways. This may be adenyl cyclase pathway or phospholipase pathway. As a result, second messengers will be rate released that produces pharmacological actions. Okay. So with this, we'll conclude the session for today. So I hope tomorrow we'll see and we'll come with the new topic. So I hope all of you understand what is pharmacodynamics and what about the receptors. So once again, I thank to this government of Andhra Pradesh, JNTU Anantapur, JNTU Kakinada for giving this wonderful opportunity for me as well as for the pharmacy students. So thank you one and all. So we'll meet you tomorrow.